So we'll go on to our next abstract, which is the oral abstract number 5. And again, this is coming from a center which is well known for research in vitiligo. Dr. Youwen Zhou works at the University of British Columbia and has been working for many years in vitiligo research along with Dr. Harvey Louis, which many of you know. And so his presentation today is going to be on vitiligo development is associated with deficiency of pro-regenerative macrophages and is prevented by macrophage secretory inhibitor 1. So Dr. Zhou.
Thank you very much. I'm going to talk about vitiligo development is associated with M2 macrophage deficiency and is inhibited by myristoyl 1. We have been studying vitiligo genomics, transcriptomics, and cellular profiling for the past several years. And today I'm going to focus on the cellular profile of vitiligo lesional skin and what we learned from this in terms of developing novel therapies for vitiligo. From transcriptome studies and using cellular deconvolution algorithm, we're able to profile the relative signal intensity of 64 types of inflammatory cells in the skin of lesional vitiligo. And we used normal skin and non-vitiliginous inflammation such as dermatitis as the control. To make a long story short, we were able to find a specific macrophage marker of vitiligo that's not present in other inflammatory skin such as dermatitis. Specifically, we found that the M2 macrophages are deficient in vitiligo lesional skin and much lower compared to the normal skin and compared to dermatitis. And this deficiency of a macrophage, of M2 macrophages is confirmed using immunofluorescence staining and flow cytometry. Macrophages can demonstrate pro-inflammatory phenotype or anti-inflammatory phenotype, the latter one being carried out by the M2 macrophages. And this anti-inflammatory effect is largely mediated by myristoyl 1 and other soluble mediators. Myristoyl 1 is an enzymatic derivative of docosahexaenoic acid or DHA, which is a form of omega-3 essential fatty acid. The conversion takes place largely in M2 macrophages, resulting in addition of 2 hydroxy groups to the fatty acid chain and resulting in the formation of a myristoyl 1. This particular mediator binds to a membrane receptor LGR6 as well as a cytoplasmic receptor ROR alpha, with the end result being resolution of inflammation. These 2 receptors are found in cells found of the in the skin, especially the ROR alpha receptor, which is expressed by most cell types, including the melanocytes. Its role has been studied in various skin conditions, especially the erythematous skin inflammation, such as psoriasis, sunburn reactions, and atopic dermatitis. In all cases studied, myristoyl 1 exerts efficient inhibitory effect in the development of these diseases in mouse models. However, to date, its role on melanocytes and non-erythematous skin inflammation, such as vitiligo and alopecia areata, have not been studied. Because melanocytes express myristoyl 1 receptor, we asked the question whether it could modify or change the melanocytes in culture. For this, we performed melanocyte proliferation assay as well as melanocyte survival assay in which we removed the serum. Normally, under this condition, the melanocyte would undergo apoptosis by day 3. With the addition of Muracin-1, we find that the proliferation on the left of this plot showed a significant increase from 100% to 142% with the addition of Muracin-1. Similarly, the survival of melanocytes under physiological distress with serum starvation, normally 98% of these cells would die, but in the presence of Muracin-1, there's a significant rescuing of the dying melanocytes. As a matter of fact, the survival increased from 2% to 41%, more than 20-fold. So therefore, we conclude that Muracin-1 can directly act on the melanocytes to promote their proliferation and survival. And this function is a novel function and is independent of immune resolving function of the Muracin-1. Now, can the melanocyte protective role observed in vitro be also observed in a in vivo situation in mouse model? In this case, we took B6 mouse model of canities, which essentially is an aging-associated degeneration of melanocytes, much similar to the gray hair development in humans. It is well known that black 6 mice by the 16 weeks of age develop canities or white hair in about 50% of the mice. We found that the mice that demonstrate white hair has a significantly lower levels of Muracin-1 in the serum compared with the mice that do not develop gray hair. The question is, can exogenous added Muracin-1 modify this development? For this, we divided the mice into 2 groups. One group received Muracin injection, where the other does not. We found that the control group had, as predicted, a significant number of mice developing white hair by 8 weeks into observation, whereas Muracin-treated group, none of the mice developed a gray hair, suggesting that Muracin-1's melanocyte protective role is also present in vivo. We then studied the Muracin-1's effect on vitiligo mouse model, in which case we injected B6 mice with TRP2 under immune stimulating conditions such as the presence of lipopolysaccharides, and using the protocol developed by Youwen and colleagues. And normally, by 16 weeks, up to 80% of these mice would develop vitiligo. We find that with the addition of Muracin-1, there is a significant reduction in the percentage of mice developing vitiligo, and in those that do develop vitiligo, the intensity and the area affected is significantly lower in Muracin-treated mice than control mice. And thus, the Muracin-1 melanocyte protective role is also evident in the setting of vitiligo. So in summary, we found that there is a deficiency of M2 macrophages in the lesional skin of vitiligo, and this results likely in a reduction of Muracin-1, a soluble mediator of these macrophages. We found that Muracin-1 can bind to 2 receptors, both of which are found in various skin types, especially the ROR alpha receptor that is found in melanocytes. We find that the Muracin-1 has a pro-surviving role, a pro-resolving role on the development of psoriasis and atopic dermatitis. And we found that the Muracin-1 has a novel, previously unknown effect directly on melanocytes, promoting their survival. and that this promotion, this pro-survival function is also evident on melanocytes in the hair follicles of mice, both in the Canatis mouse model and in vitiligo mouse model. So therefore, we would like to propose M2 macrophage deficiency mechanism of vitiligo pathogenesis, in which the normal skin contains a healthy number of M2 macrophages that through its soluble mediators such as myrisine-1, a healthy growth environment of melanocytes is maintained, allowing the production of a healthy level of pigment. And in some situations, when there is a deficiency of M2 macrophages, there's also a deficiency of the lipid of the soluble mediators such as myrisine-1, resulting in a non-friendly environment for the survival of melanocytes, causing the development of vitiligo phenotype. We further propose that exogenous added myrisine-1 can substitute the function of M2 macrophages, restoring a healthy growth environment of melanocytes in the skin, thus blocking the development of vitiligo. So in the future, we are proposing to study the myrisine-1 or its structural analogs as potential therapies for vitiligo or other depigmentation skin diseases. Before closing, I would like to thank the researchers in my laboratory at University of British Columbia, especially Dr. Youwen Zhou and Gigi Liang, my technician, and my long-term collaborator of Xuejun Zhang in Anhui Medical University and Pinyu Zhou in Shanghai Skin Hospital in China. This study was supported by generous grants from Canadian Institute of Health Research, National Natural Science Foundation of China, as well as Canadian Dermatology Foundation. Thank you very much.
Thank you, Dr. Zhou, for this fascinating look into macrophages in for vitiligo. I don't know if Dr. Zhou is on the in the meeting, so he can answer some questions. Does not look like it. There are some questions about the effect of do JAK inhibitors or phototherapy have any effects on this MAR1, and any drug delivery methods for MAR1 for other diseases. So I would like to know, why is it that these macrophages are deficient in the vitiligo skin? But I guess Dr. Zhou was on, but oh, you're getting him back. Okay. Well, hopefully he can get back and answer a couple of these questions on the macrophages. There is a lot of research being done in other fields, pulmonology, rheumatology, on macrophages, and we know that macrophages are involved in the skin. For example, melanophages are a problem in acquired dermal pigmentation, and so this type of research and looking at how to mobilize macrophages, either to promote macrophages or to promote removal of melanin, is something that's needed. Oh, there you are, Dr. Zhou. Thank you for that very interesting lecture.
Oh, thank you. Sorry, I for some reason I was kicked out of the live participation Zoom link. I had to reconnect. Sorry about that. Sorry,
No
I
problem.
probably missed the questions.
Well, we are glad that you are back. We're glad that you are back. The question has to do with, well, there's three questions. One is, why are macrophages deficient and why are they deficient? Why is there less of this MAR1 in vitiligo skin? And do JAK inhibitors or phototherapy have any effect on the MAR1? And any drug delivery methods for MAR1 for vitiligo or other diseases?
Well, these are great questions. The first one about why there is an M2 macrophage deficiency in established lesions of vitiligo. I have been wondering this question as well about what exactly the cause of it. I don't have any clue, and I think there's something inherently different about vitiligo, and it's probably there's something in the skin of the environment that basically results in the chronic deficiency of this type of cells. And we know this is not, initially I thought maybe this is present in every type of skin or inflammation. So that's why we actually included dermatitis as a control. But this deficiency is not present in dermatitis. So there's something uniquely different about the skin of vitiligo. And that's obviously an area that we want to study in the future, but it's not easy to do the study. And but short of directly adding the M2 macrophages direct to the skin and see if they survive or something, I think there's something that inhibits them. So I think we've gone one step that shows there's a deficiency, but we don't know the answer of why. And in terms of the other questions about the JAK inhibitors treatment or UVB treatment, whether that modifies this, I do not know the answer. But my hunch is that because UVB and JAK inhibitors are inhibitory of the immune system, and we know that when the active immunity is inhibited, usually there is upregulation of M2 macrophages. So they undergo like a phenotypic switch, but I have not studied that. Now, in terms of delivery of Maricin 1, it is actually a small molecule. Its molecular weight about 350, 320 kind of thing. It's well within what dermatologists would believe to be able to to basically permeate the skin. And we do know that in our mouse model of atopic dermatitis, when we actually apply this molecule topically on the skin, it actually does efficiently inhibit atopic dermatitis. So I believe it is able to do that for vitiligo as well. It's just we have not formally studied. So in our actual vitiligo model, we end up injecting that intraperitoneally, but this thing could also be delivered by oral consumption, injection, and as well, I believe in the future topically. And that's an area that we might actually be testing next when we get around to it.
That's a very exciting, Dr. Zhou. We look forward to seeing the results of your future research in looking at active versus inactive vitiligo, face versus hands versus feet versus body, to see if there's a difference in dark skin patients versus light skin patients, older versus young patients. And then, of course, the delivery. Topical sounds very exciting, oral as well if there's no toxicity. So there's a lot I can see that's coming from this. So thank you very much for your presentation. We look forward to hearing more from you in the future.
Thank you.